Welcome to the Journey Podcast, a show dedicated to health, wealth, and happiness. Join us on the journey as we explore the world your health and wealth make possible. Welcome back to the Journey Podcast. Today we are joined by Dr. Meighan Patton. Meighan is a co-founder of Acropolis Health, a dedicated physician, wife, daughter, mother, and entrepreneur. And Meighan, thank you for joining me today.
Thanks for having me.
Appreciate it. We had the chance to have your husband on, Dr. Brad Patton, and the co-founder of Acropolis, and we touched on the transition that you both made coming out of the healthcare space into founding your own practice, which would love to start there and just get your perspective on that transition, you know, where you were and where you are now and what made you want to create that bridge.
Mm-hmm. So like Adam said, I'm a family medicine physician. My husband and I are both family medicine physicians. We went to school together. We started our first job together as well, in the same office at a hospital system. And we spent about 5-6 years there together, working at full capacity. And what that means in a typical hospital setting is that we would be responsible for anywhere from like 2,000 to 4,000 patients. It was getting clear to us that the way that we prefer to practice wasn't going to work in that setting, having to squeeze in 15-minute appointments and then finishing up work after the kids go to bed. It just wasn't going to work for our lifestyle and our goals. So right when we actually got pregnant with our second child, we realized, yes, this is going to have to change. And whether that means we do something out of medicine or have this direct care concept work, it was gonna change by the time I had the baby. So what we did was we started to do a lot of our research about direct care, and what that is just our patients pay a monthly fee. We don't bill insurance, so it's direct access to us, each of us, and we spend more time with our patients. We have a better, more comprehensive approach to each individual patient's goals and care. And all the kind of sort of back end games that we have to play with insurance, we don't have to spend time doing that, and we don't have to justify each visit. So it could be something, a minor issue, or it could be a really complex issue that we tackle. And we could do it over the phone, over email, or in person. So we ended up quitting or leaving our position at the hospital system together and opening this practice. And we've really gotten to sort of allow our interests to blossom. We are really finding ourselves doing what we really love to do and are interested in. And what that is for the both of us is taking care of families. We love a family unit, and I tend to take care of the women and kids. And my husband, Brad, tends to take care of the men. He's interested in men's health. So that's what led me to becoming interested in really having, being forced to be somewhat of an expert in perimenopause.
Thank you. That's great. I mean, it provides a tremendous amount of context, and the story aligns very well, because I think two things you referenced. One is time, personally, your time, the system you were in. Two, how you spend your time with your family, and more importantly, transitioning to spend more time with your patients.
Right. Yeah.
And you, again, segued right into the topic I think we're going to anchor to today is perimenopause. Mm-hmm. And specifically, one of the reasons I wanted to talk to you about that today was we work closely with you both. We wrote a newsletter, which we have at the firm, that we put out to our clients. And the topic was truly around women's health. And you wrote a piece for us within that, anchoring to perimenopause. And I will say we've been writing that for a while, and the response that we got was really thoughtful and engaging from people who had read that. People stating, hey, this is describing me specifically. It's like you're talking to me. I'm absolutely experiencing these things. And, lastly, that, this needs to be talked about more. I want to learn more, because what can I do? So could we start by just defining that idea of perimenopause, what it means, some of the symptoms you see from it, and kind of a multitude of the degrees within it?
Yeah. When you asked me to do that, that piece about women's health. You sort of gave me a broad topic, and I could have chosen something that had a lot more research behind it, but I really wanted to tackle something that I see personally being so important and needing to get more coverage, basically. And that was the topic of perimenopause. And there's a few reasons why I think, for one, it's not talked about very often, and people feel like they're not getting a lot of information about it. And one is that it's hard to collect data that confirms you're in perimenopause. This is a clinical diagnosis, and it starts. So there is a textbook definition by the North American Menopause Society, and that is there are 2 phases of perimenopause from their textbook. I just say that because there are some sort of like a little bit different opinions about how many phases of our, and we can talk about that in a second, but the 2 phases of menopause or perimenopause are, so before your last menstrual period, there's a phase where hormones are starting to be a little bit more imbalanced. The progesterone has declined since probably your mid-30s, and that varies widely. So some people can start after, if they've had like 3 kids, it can start in their late 20s, it can start in their early 40s. But progesterone starts to decline, and then there are subtle like menstrual irregularities is kind of like how the perimenopause society or the menopause society defines it. And so when you have more than or equal to 7 days of a difference in your period interval, so that's somebody who has regular intervals, which is, it's common, but it's not really that uncommon to have irregularity. So it's very hard to sort of use that as a compass. And then during that period of time, there are a lot of symptoms. It's not something that we've necessarily talked about or gets a lot of importance in, for instance, a textbook or medical school, but that's the start, is that your periods start to become irregular. The next phase is the late perimenopause phase, where a period interval is 60 days or more. So then you get just a lot more irregularity. And then you have the final menstrual period, and then that year that it takes to make sure that you are like actually in menopause. It's a clinical diagnosis. After a year since that last menstrual period, then you can call yourself in menopause. And then there's that little phase of that year where usually symptoms are pretty maximal, like hot flashes and stuff like that. And that's what we usually think about of perimenopause. In my practice and in reality, I don't believe that it's really that easy and cut and dry as like your periods are irregular. I mean, there's so many differences. People have PCOS, endocrine issues. They have, different surgical procedures that make them stop bleeding, or they have IUDs. I mean, there's so many things that you can't just say, oh, you're in perimenopause because you have an irregular period from your perfectly spaced period before. It just doesn't happen. We have a lot of women having kids in their late 30s and their early 40s. So nobody really knows. So there are, like I said, there is a problem with sort of confirming that you're in perimenopause, because there is no one marker that you can say, like a lab marker that you can say, okay, you're in perimenopause. There's no test. There's a collection of hormones and biomarkers you can sort of follow somebody over time, and you could say, this supports that you're in perimenopause, and all the symptoms that you are describing support it. But I think that's one reason why it doesn't get a lot of, because we don't really know, we don't have like a real firm stance on that. I mean, another thing about perimenopause is there's a massive gap in research. So there's finally a lot of research in menopause, but perimenopause, that time where I'm talking about like we don't really know what to call it, there's just no research. Like I'm going through the menopause textbook right now, and there's like a little section on sort of the phases of perimenopause, and I go to see what the references are, and it's like the studies were done on mice. Like the mechanisms that are driving these symptoms, we don't even know truly are these going on in humans. And then the third, I mean, the reason that I think that doesn't get a lot of attention, that we don't like address it very well or really know what it is that there's honestly, I think there's not enough women practicing medicine who have the time and energy to focus on this. So most women in medicine, over half, I think last time I looked, it was like nearly 70% of women in medicine are burnt out. Like they have reported burnout, which is a lot higher actually than men for a lot of whatever reason. There's like, a lot of proposed reasons. But but we are not allowed the time to address it in a typical office setting when you get like 10 minutes with a patient. And you don't have time to research it either, for sure. You're just catching up on work as much as you can.
Yeah.
Realistically.
Well, there's a lot to unpack throughout that whole piece. I think what I took away from everything you just shared is really, one, right, there is no set test. It's like when I go get my blood work done and I can look at ApoB, for example.
And you're like, this is the crux. We have a number we can work with. Yes.
Here's the line. If I'm over or under, I know where I am, right? So from that perspective, there's a lot there. It's broad. It's not extremely defined. And I'm assuming that doctors, researchers, and just the health space in general hasn't agreed upon everything within there.
Right. And
to your point, you're talking about something that's a little more nuanced than just menopause itself. So I think one, that is there, and two, the back end of that, meaning who's working on it and how much time is being spent on that. To your point, and I talked about this with your husband. I'm familiar with it. I know you're familiar with it. When, you referenced at the beginning of this 2, 3, 5,000 patients per family practice doctor. We talked about, again, on that show, the time spent with patients in a typical checkup, right? It's anywhere from about 12 to 21 minutes and anywhere in between there, which, to your point, we've just covered that topic for 10 or 15 minutes. And you're just at the tip of the iceberg.
Raise the surface, yes.
So I think when you share both of those items, I want to bring it back up and ask you, for your patients, when they come in sharing those stories, and if there's anything you would, stories you share either personally or what you have seen, we'd love to hear those. But, when you start to hear those, how do you start to recognize and transition them to start thinking about, hey, this is potentially something that you're looking at or entering into? And how can we start to think about that in terms of not having to live with it, meaning how can we start to transition to look at it and approaches we can take and everything that falls within there? Yeah.
I would love to contrast what I used to think when I was in that hospital setting, sort of like grinding it out. And now when I've had time to think, I'm not pressured, I can sit down and connect with somebody and notice patterns. Back when I was out of residency, in first few years of practice, I look back and I sort of cringe because I'm so many situations that I saw. I'll give an example, sort of a more extreme example that'll be burnt in my memory, about identifying when somebody's in perimenopause and being able to sort of help them, hone in on how can they adjust to improve their symptoms. The problem is, and many practitioners who have been in it for decades, they admit this is something when we look back, we can say to a patient's sort of series of symptoms, oh shoot, you were in perimenopause. That was probably mainly why you're feeling all these things. But especially before I got to dive into it more like I have now, there was a situation that, like I said, I'll remember forever. This woman was the most poised, put together, late 40s, mom of teens. She had a really prestigious job. I feel like she was a lawyer, something very she had herself put together. Never had a shred of anxiety, insomnia, really took care of herself. Wasn't overachieving either. That's kind of something I'll talk about. But suddenly she started to just not sleep for no reason. She was experiencing days and days, and it turned into actually months of insomnia where she wasn't sleeping for days at a time. She was experiencing severe anxiety and panic. She would have the occasional hot flash. It wasn't something that it was she's hot flashing, we know what's going on, and even so, I wouldn't have necessarily known to say that insomnia is the reason. So, I'm getting her hooked into all the things we have, the cognitive behavioral therapy, the just sleep hygiene ad nauseum, just, all the lifestyle stuff I can consider. I tried an SSRI on her, which is an antidepressant medicine, one of the sort of approved medications we use for hot flashes and menopause symptoms. It also happens to be an antidepressant medication. I mean, like it was so resistant and difficult. And now I look back and I'm like, oh my gosh, like that woman was in perimenopause. And I got to like sort of unpack that with the therapist later on. I see more people like this now that I've seen that and some other symptoms that are almost like without fail. I'll have a new patient nowadays in their 30s to like early 40s coming to me with the same complaints. I mean, I want to say like 95% of these females are reporting some sort of mood change. Like they're sort of suddenly becoming like irritable. They sort of don't have the patience they had for people or people around them or the situations. They have a hard time multitasking. Not that anybody can multitask, but like handling the things that they normally could, like their job, their kids, their house stuff, you know. They're reporting insomnia. Usually problems with sleeping is a huge one. A big one definitely is the central abdominal fat deposition. So like they're just body composition changes. And despite the fact they're doing the same things, and a lot of them are exercising more. They're trying to cut out all the things like all the carbs and all the sugar and like exercise more. And they're just not getting any kind of response. There's a lot of other symptoms, I mean, that are kind of a little bit more rare as far as when early on, but those are the main ones that I'm like, okay, I see a little shred of like, I think this is part of what's driving this. And not that I, have some magic pill for that, but we have some other, I'll be changing our mindset and our perspective about how we approach that, that situation. So we just, as far as like how I would approach that, like I would with most problems, but just like I said, in a little bit of a different lens. We go through kind of like the pillars of their health, So what I consider is like their nutrition, their exercise, their sleep, their stress. There's others that, if we have time, we get into them. But so there's like some adjustments that I think everybody could use in this phase of their life that will improve their symptoms based on what we think the physiology is that is driving the symptoms. And I mean, we could talk about those in detail later, but the next phase of perimenopause, when I can say, yes, these period irregularities, these hot flashes, night sweats, these more significant symptoms, we're in full-blown perimenopause. Here are some more options that include possibly medications, and not everybody's a candidate for menopausal hormone therapy. But there's just like, as far as like the combination of treatment options, there might be 100, so as far as medications go, hormone and non-hormonal. So it's just an individualized approach. It takes a series of visits of getting into this for probably over like hours. And so one thing when I talk to people, like my friends in the neighborhood who are my age, they're like maybe a little bit older and they're experiencing some of these things. I'm like, listen, we could talk about all this, but like you really just need a longitudinal follow-up with a clinician that you trust that knows this topic. And that's kind of the biggest thing is we can get into details of like what I personally do for people or recommend. But the biggest thing is just being able to recognize it. A lot of people are resistant to the fact that they're in perimenopause. So I have a lot of females who kind of, not ageist is a strong word, but they're just maybe afraid to age, you know what I'm saying? Mm-hmm. Like, and it's just such a taboo and such a negative connotation to like getting into menopause. You're just like old and shriveled up. You know what I'm saying? Like nobody wants to be, especially when they're like peaking in their career and they are the pillar of their community. Like, you know what I'm saying? Mm-hmm. So that's almost like a fault. And instead sort of like identifying, creating a plan, changing mindset, and then they can become empowered about like, okay, this is how I'm going to like, fly through it, because it's only a moment of time in their life. Like it's not, it doesn't drag on for the rest of their life. Like after menopause, things actually kind of like smooth out. And there's other issues, but yeah.
Yeah, I mean, that's great. There's a lot again there, but I really appreciate that story. I think is really thoughtful and sets the stage for a few other items. But I want to bring it back to some of the symptoms, right? Because I think what you said is, hey, brain fog, the hot flashes, the insomnia, the lack of sleep, right? All these things that can cause people for lack of a better term, to spin out in other areas, meaning, hey, what's wrong? Why am I not sleeping? We know what sleep does just in general, or lack thereof. Like the implications across mental health and physical health is absolutely huge. What that does, to your point on the cognitive piece of it, whether you're a physician, a lawyer, you stay at home, or a teacher, right? The implications of not being able to go in at your best self is even bigger. So when people start to face those, and then they start to ask those questions of what is causing this, to your point, you mentioned that specific patient you worked with. I want to untap, like, okay, now we understand, like, these are some of the symptoms. These are what we are seeing. Historically, the medical space would have maybe not, years back wouldn't have recognized some of those things. Now we're starting to recognize it, or specifically in your practice, you're recognizing it. What are some of the things you are then starting to think about? What was that conversation perhaps with her, or another example of, all right, we're recognizing it, we're seeing it. What can we start to do about it?
Right.
That you kind of referenced earlier, whether it's like, hey, these are the initial things we can do. And then how do we build that plan 3 months, 6 months, and as you transition out into menopause and beyond?
Yeah. So going back to that one story, one piece, and this is not uncommon, I see this a lot. This woman was taking herself to the ER multiple times because of the feeling of, she was essentially like dying, like she was having like palpitations, chest pain, new hives, like an allergy that developed out of nowhere to a food product. And we know that those are things that happen. And so the first thing is to work through these issues from a medical perspective with a trusted physician or clinician and somebody that's taking you seriously, because we can't just say like, oh, these palpitations are your perimenopause symptoms. Like, I'm going to have to work that up. So it takes a little bit of time to kind of work through what is more like medically driven, that is like has a condition. And once we rule those things out, then we can talk about, some of the diet, nutrition, lifestyle things. I would say, like, if I'm going kind of down the line with people, I identify anything that is promoting inflammation in their bodies, whether it's the type of food they're eating, like highly processed food, a lot of sugar, a lot of fructose. They're not getting enough fiber, prebiotic fiber. I focus a lot. I could do a whole visit on just somebody's microbiome. Like, I talk so much about the gut microbiome and a lot of ways to improve it. One being obviously dietary changes. So in adding, and most of the time I'm encouraging not to like restrict something. Whereas before we, kind of recommend like to cut out carbs, that is not good to support someone's hormone balance. There's definitely a balance that should be struck, like kind of identifying where you can cut out highly processed carbs. But mostly I'm asking people to add prebiotic fiber to their diet. For breakfast, people are terrified of feeling full. Females are just subconsciously like, I don't want to get fat. I'm feeling bloated. It's part of the perimenopause thing. I can't eat. I can't eat until I stuff myself later because I'm afraid I look like I'm pregnant. You know what I'm saying? Mm-hmm. So I encourage the addition of prebiotic fiber. It takes some time for your gut to kind of change. Not that much time. It's not like a year from now you're going to have an improvement. It could take just weeks. I ask them to add protein, like almost across the board. Nobody's eating enough protein, females, I generally kind of just go about it that way, to kind of like focus on, I love how, I don't remember who originally kind of put this idea out there, but I've adopted it, where I'm like, just focus on your first and last meal and like let the rest go, because you have all the other stuff in your life you have to take care of. Like, try not to be perfect all day long. It's impossible. So if you focus on your first and last meal and you're adding all the prebiotic fiber and protein that I talk to them that tailor their specific needs, and then fill it in with like veggies, fruit, and just let it go when you want to have some other type of food that you feel is unhealthy or whatever. Because for the most part, you're doing pretty good for yourself if you start there. I ask people across the board at this phase of their life to stop or like very much limit alcohol intake to, at minimum, like 1 drink a week. To be honest, like if you want to feel better and you're having these symptoms of perimenopause, insomnia, like weight gain, all this stuff, then alcohol is just an intentional decision to like go against that goal that you have for the moment. And that's okay. Like if you want to have a good time with your, group of whatever, like Memorial Day, you just made that decision that you won't get good sleep. That's it. Like there's a decision. And then as far as exercise goes, oh my gosh, like most of it, it all depends on sort of people's sort of baseline lifestyle, but I take care of a lot of people who are, business owners. They're juggling multiple things. They're taking, like I said, care of, could be like toddlers and young kids, very needy, people, and also their parents. So they're sort of stretched thin. And I feel like that's the biggest deficit is exercise and just be moving in general. So like, that's not something I have to tell you. I'm sure people in your podcast have already spoken about this, so I'm going to just leave that one. But I could say like, that's probably like the number one thing I'm like, just at minimum and a way to kind of like start it if somebody's really not doing anything or if they're kind of doing too much. I'm like, let's check in and see how much. It's easy for me to tell somebody about zone 2 just because that gives them something to work on. And as much as the science, as we can tell, that is kind of like a zone that will improve metabolism and things like that. But so I ask them to do at least 150 minutes of zone 2 exercise a week.
And I'll reference zone 2 is just, if you can carry on a conversation, you are good.
Yeah.
Right?
Yeah. Like you can, right. Somebody knows you're kind of like exercising, but you can still sort of chat back and forth. And muscle building, that is something that I feel like I could count on one hand how many females my age are like muscled, like adequately muscled, And again, it's one of those things where people are terrified. I say to people, like females a lot of times are terrified of looking big. Like they want to look thin and they're afraid that if they add muscle, they're going to look like, you know what I'm saying? But what they don't get is that is what improves your metabolism. Like that's how your body handles the sugar that you do take in. So anyways, I encourage them. I like challenge them, like just try it for a year. Like try to exercise, like where you're really physically challenged. And I oftentimes have to direct them to like a personal trainer, or I oftentimes have people follow people on YouTube that I like just for motivation and like guidance. And I'm really asking them, challenge yourself with the weights, like go up and up and up. You can't just be flinging around 5-pound weights and make that be something like, so that's a huge topic. And probably I keep saying this where I'm like, this is the most important, but I seriously, with the perimenopause community, probably the number 1 and 2 thing that I would say make the biggest impact, because a lot of my patients actually, they are focusing on those things and they're really like honed in. They're like really dialed in. They've done a great job with these things. And I'm like, shoot, like we don't have much to tweak. But then I look at their sleep and their stress and I'm like, whoa, we have a lot to work on, and this could take a lot of time because it depends on how severe it is, but it could be everything from like starting with a therapist, which also has some baggage. Some people still feel that's very taboo, to like vulnerable, like there's something wrong with them that they have to see a therapist, when I'm like, it's really just about optimizing your life right now. Like you don't have almost like the luxury of getting it wrong and kind of being wishy-washy like in your 20s. You're like, if you want to get it right and improve your symptoms, like probably just get some help and get a therapist. There's also workbooks out there, like cognitive behavioral therapy type workbooks. But and then the sleep, I do spend the visits about sleep hygiene, sleep improvement. So and then all of that, I'm usually kind of partnering with a lot of people in the community, therapists of different sorts, like personal trainers, life coaches, things like that. So, and then kind of like the next level, the next step that I talk about are medication options. And that includes, I include supplements, because that's like every single supplement I recommend, I like scrutinize just like I do a medication. So depending on what people are, having problems with, like focus, I'll have a lot of patients who all of a sudden, sort of myself, they juggle a lot. They're perfectionists. They, are high achieving. They're doing it all. And they're trying to also write a book or whatever. And they're like, I all of a sudden can't focus. And I'm like, yeah, I could see that. Anybody else would look at your life and be like, holy, how do you focus? And so, yeah, there are some things to do about that. And like a supplement you could try. Like we don't have to jump to having you on Adderall. That's where people kind of like feel like, oh, I just need an Adderall. I just need a GLP-1. You know what I'm saying? And then as far as the medication options, that's something I'm just recently being more comfortable with addressing and prescribing, because that is such a taboo. Another sort of something that basically physicians in my generation and for like at least a decade before have been afraid of prescribing hormones because of, I think most people are aware of the WHI study published in 2002 on the nurses about hormone replacement therapy. Well, it's called menopausal hormone therapy now. And there were some negative outcomes, but it was because of the study was done improperly, basically. So it was a little bit misleading. The way that we prescribe hormones today is a lot different. The type and the timing is different. So, yeah.
So that's, I'm going to back up. You covered a lot because I really want to talk about the lifestyle changes that you referenced at the beginning. And then maybe we'll come back to that hormone piece, because I think what you are saying is, or what I'm hearing is like, this is an opportunity in two ways, meaning, okay, you're starting to recognize what this is. It's not some random thing that's happening. Like there's an explanation, you're experiencing it. And there's things you can start to do for it. And I talk a lot about this, and with the guests we've had on the podcast, things we do in the firm, and at least in my side of the business, is a lot of it anchors to lifestyle. Meaning you're going through this, and then it's an opportunity to step back and say, okay, just like you referenced, what is my diet and my nutrition? What am I eating, right? Is my diet heavy in processed foods, fast foods? Am I drinking calories? And what I mean by that, Coke and Pepsi and all of those things, the fructose and the sugars. Two, am I exercising, right? Like you've used the term magic pill. I would tend to argue like exercise is one of the magic pills across the board. And it's twofold within that, weights and cardio, right? And I would agree there's some amazing podcasts on, from both male and female trainers around, weightlifting. And to your point, the stereotypes and the ideas that people assume, I don't want to lift because I'll get bigger the minute I touch a heavier weight. And we know what often happens is you tend to lean out. And to your point, like on a nutritional perspective, not even pivoting into, as we get older, starting around 30s, right? We start to lose muscle mass, both, in decades and eventually in years. I think over the age of 50, it goes to about 1% to 2% of loss of muscle mass per year, which
that's detrimental for like females. I mean, in males too, but bone density and everything. Yeah.
100%. I talk a lot about, we're a financial firm, so compounding interest, right? Like you compound that over time, like, wow, right? Like that's impactful. To your point, mental health, right? Like we know, I was just reading an article this morning around isolation and people feeling it from work because of coming out of COVID. And what I mean by that is, Zoom meetings and like work from home and the implications to isolation and loneliness. And why I tie that to here is like, if you don't have a practice or a protocol for mental health, right? What I mean is, if you're an entrepreneur, like you work with a lot of them, or, people in high stress professions like attorneys and physicians, executives, right? Like you're experiencing stressors both in the professional workplace and at home, and the impact that if you don't have a program to approach that, there could be a multitude of things. To your point, you talked about, cognitive behavioral therapy, breathing techniques, meditation, yoga, right? Whatever it is, like there's a plethora of choices out there. And then lastly, sleep, right? All of those then spiral into, it's like sleep is the cocktail of all of those that, if you're not sleeping well, to your point, alcohol, nutrition, exercise, stress, right? Yeah. Any one of those or all of them are going to dramatically impact your sleep. And then we know what that does, right? So, right. I look at it, everything you shared today. One is it's impacting that specific item, but I also think it's just an amazing opportunity, and at least trying to turn like a negative people are experiencing into a potential positive of, hey, let's start with lifestyle change. And that's what I love. Everything you shared is this is a perfect opportunity to start in lifestyle change, meaning we can do all these things. And let's say, right, like if you adopt these, not only does it help this issue, but more broadly, you are now building this, like you're building a life, meaning all of these positive habits that are going to impact this to help, bring it in, but a multitude of other things into the future. So talk to me a little bit like how you've seen that reception with your patients, and then we'll tie that on because to your point, somebody can do all of those things, right? And then we just have to look at the meaning prescriptions or hormone therapy. But I'd like to first just start with like what you've seen when you see people starting to adopt those lifestyle choices.
Yes. The fun thing is that now that I'm in this setting where I get to spend time longitudinally and I get to really dig into people's lives, what drives them, what their barriers are and everything, I get to see who is benefiting, and the outcomes are favorable and what things don't work, And so like number one, I guess like, again, starting out I used to get a little bit sort of hesitant at just being another person telling these people what to do with their diet, exercise, yada, yada. You know what I'm saying? Like almost like cookie cutter. They've heard it 100 times. I can almost see them rolling their eyes, But the first step that I feel like gets me a little bit of credit is, for one, like telling them something they've never heard, which is after we've gone through all the things that the medical things, this is at least in part due to the phase of life you're in, which is perimenopause. So like validating that they're feeling these things and this is expected and within normal, this is a normal kind of expectation. And there's a lot of people, like I tell them like how many females are experiencing this. And they're like, I almost like have the highest executives just sobbing, like crying and being like, nobody's ever told me that. I feel so much better, so it just kind of starts there. And then I tend to ask people to chunk it out. I like seasons of the year. So like for, it's just too much to tackle for a lot of people and they feel like, oh, I can't do it all. So then they end up kind of like giving up. And that's why, like I said, creating an individualized approach. Like I'll have one patient I'm thinking of that was doing a lot of good things with her nutrition, lifestyle. Like we did a couple little tweaks, but basically I've let her go there and we focused on her gut health. Like I added, a probiotic, which I don't across the board for everybody. Like this is something that was specific to her. I asked her to do like an elimination diet, which again, I don't do to a lot of people. Like that is very specific to her. It ends up, with this probiotic, she eliminated gluten. It turns out she had a gluten intolerance. And little tweaks to her exercise. She has felt, she cannot tell me how like amazing she's felt. And it's only taken like, not even, I want to say 6 months. Like it was not that long of a time. This happens a lot where I ask people to do the highest impact things because they don't have a lot of bandwidth. Like they're just, if I give them like 1 or 2 things in each category to be like, this based on research and based on you personally is probably going to be the highest impact change you can make. And so I have them adjust like 1 or 2 things and give it like, I'll follow up them in like 2 months. And like, how did you do it? What are the barriers? Okay, you're doing great with that. It's almost like part of your routine. Let's continue that. And we'll add or subtract like something else, like 1 or 2 things in each category. And so just like, and also a lot of people just feel better if they just chunk these overwhelming things out into, I prefer seasons because like it feels better to do certain exercise during the summer versus the fall versus the winter. And so that's kind of like what I have people do. And any individual person might be doing really good in one category, like I said before, and they really need to lean in on like going to therapy, life coach, figuring out their, boundaries with their family, their work, their, you know what I'm saying, to be able to get the time back for self-care and to take care of these things. So like you said earlier at the very beginning, this is a moment to be able to like reflect. And this is like a major thing, like where this allows you to pause. You really have to pause and take inventory of like what is taking up your time and what does it align with your goals, your purpose in life, your legacy, however you want to say it. And there's ways to go about evaluating that, and let go of things that don't serve those goals, purposes, and lean in on things that maybe you've built up a lifetime of being afraid to pursue because you're afraid of failure. Because of, again, we're old enough now that we've gone through failures and we don't want to do them. That's a subconscious thing. We don't like to be uncomfortable. So like letting go of things or people, relationships, and then also pursuing things that, you're sort of afraid to do, but it does align with your goals, and giving yourself some grace, by means of, frequently checking in, like this mindfulness I'm talking about, and delegating. Like you're sort of like you're a boss now. Like, you know what I'm saying? You're not like, you're at this phase of your life. Most of the time you have people, I don't want to say under you, but you know what I'm saying? You can identify areas that you need help and employ that help. You know what I'm saying? And so just being smart about that, about boundaries, about just, during this month or this time of the month, I'm going to have my secretary do XYZ, and just kind of like, you know what I'm saying? So, so be a little bit more in tune to your body and your needs, because it's not that you can't excel. Many females at this time of their life are excelling in their career. They're starting a business, or they're trying to grow their business, or they, are writing a book or whatever they're doing. And just because that there is a stigma and there might be a little bit brain fog, it isn't that you can't achieve these things. It just like has to take some intention, and maybe letting go of some other things that are taking your brain space.
Yeah. It sounds like within the practice, what you're trying to do when people are going through this specific item, your patients, is right, recognize it and then empower them to understand it, and then send them on their journey to how can we start to make these changes. And I loved how you use seasons. It's one of the reasons we moved back to Ohio from Arizona. Arizona had no seasons.
Yes, Florida too. Yeah, we live in Florida.
Coming back here. But I think that's such a thoughtful way to think about it. And because there's back to that idea of like, hey, this test tells me I'm in it, and then this test will tell me when I'm out of it, right? Like, oh, I brought my number down, so I know I'm safe now, right? Like that doesn't seem to exist. So there will be test and learn along the way. And to your point, if you're not exercising at all, what a great place to lean into to start to make change versus, okay, you're doing all these things. Now we're testing, learning around the fringe. If someone's doing fundamentally some of these things, where else can you add in? And then that's the last piece. So when people say, hey, I'm doing all of these things that you've told me, whether it's your patients or what you've seen in research or work, I want to just make sure we cover just briefly that last piece of, hey, the clinical type approach, meaning, hormone therapy, prescriptions, whatever it is. How can people think about that as a potential need? And what should they think about if they go down that route? Yeah,
it is super important to know that you're in perimenopause, because the ideal time to start, if you're a candidate for hormone replacement therapy or menopause hormonal therapy, is in the probably late perimenopause time. So before your last menstrual period. You don't know when your last menstrual period is until you've gone a year without it. So, but being able to identify that you're in the right space, because studies are showing that if you start it before, you've been years after menopause. And we think of like, for now, everybody's kind of working with the 10-year mark. Like, we're not okay with starting somebody 10 years after their period stopped for some cardiovascular reasons. But if you start it before your period stops, and right now the FDA indications for menopausal hormone therapy is hot flashes and night sweats. So, you kind of have to have somebody who works with you if that's not like the earth-shattering thing you're experiencing, but it's like everything else. And also you care about maintaining your bone density, you care about improving your cardiovascular risk over your lifetime. Extending your life. In general, that is the truth. Then you need somebody that's going to be almost like walk out on a limb with you a little bit and give you the options, which are, like I said, non-hormonal, which right now we have like Paxil is one of the approved SSRIs. It kind of goes against my, I hate to prescribe it. In fact, I never do, because it's very difficult to come off of and it can add weight to somebody. So it's against what we're trying to do. And then there are the hormones. Like I said, back in the day, it was oral estrogen. It was not bioidentical. So there's some risks that came with that without getting into the details of it. Now, we tend to start with a transdermal estrogen, which lowers the risk of any kind of clot. That was the risk before, and cardiovascular risk. So that is a patch usually. There's like 20 something different formulations of estrogen though. There's like a lot of options, depending on what you like. So that would be the systemic type. And then if you have a uterus, you have to be taking progesterone. You can either take it orally. This is a bioidentical product, different from like the compounded stuff of previous, some people say bioidentical and they mean compounded, but this is actually FDA approved. This is what we use standard. It's called oral micronized progesterone. So you have to take progesterone, or you can have an IUD, which is a long-acting reversible contraception that's put into the uterus. Most people know what that is. So that'll protect your uterus from any kind of like proliferation, like the excessive growth of the uterine lining when you're taking estrogen. So that's generally, I mean, there's a lot from there. And then we continue somebody, I mean, depending on your symptoms and how you want to go about this. I have like 90-something-year-old women on the hormones, like they want to just continue. You know what I'm saying? And we don't have a ton of data that says, when do we stop? When is the safest? I mean, most people, we all have sort of loosely agreed to continue for 10 years. That would be our safest, probably stopping point. And everybody's decision is different. It doesn't mean that you're going to go through menopause in 10 years and have all those symptoms. It's not like that. This is almost meant to like smooth out that transition, give you a little bit extra help with your bone density, all the things that I mentioned. And then there's something wonderful that I think like everybody could probably use, with the exception of a certain type of breast cancer, but even people who have been breast cancer survivors can take this of certain types, is vaginal estrogen. And that can help a ton of symptoms that leads to, I mean, all the symptoms beyond the late phase of perimenopause and beyond, is like vaginal symptoms. And so it improves quality of life. It improves like mood and symptoms a ton, and like pretty much everybody can use it. So that's something that like, if you have symptoms, you should be able to go to your doctor, your primary care doctor, and go ahead and ask for some vaginal estrogen. That's pretty much it. You don't have to have any opposing progesterone or anything.
Okay. Well, I think that's a good way to kind of finish that component of the conversation, right? Is like, hey, I think about things in glide paths, and I think that's what you've talked about today is, from that very beginning, when you start to feel those symptoms, all the way to what you can start to think about and adopt to do, that are in your control, and then finding the right people to help you to kind of get to that next level when you've done all those deliverables. And as we close out today, I just have two final questions for you. One, we always ask on this because it's an important part. You use the word, people don't like to be uncomfortable throughout this. So I want to kick it back, because we do always ask, what is on tap for you this year that is going to put you out of your comfort zone? And then the last piece to close out is kind of, where can everyone find both yourself and Brad?
Oh, yeah. I don't have anything that I'm physically striving for, like a marathon. I'm always looking for something. I don't love to run, but I'd do anything else. Probably the biggest thing is that I'm working through this, like I said, textbook of the menopause textbook. So there's like this North American Menopause Society that they will certify clinicians to be menopause experts. And while I don't like need to have that to prescribe, I just want to make sure I'm doing the best by my patients. So I want to know everything from that, evidence-based world. I'm going to, dive into the functional world, just to kind of have a wider breadth of knowledge. And so I'm going to take that test. So it's like a 250 question exam, and that's not fun for me. So that's what I'm doing. I haven't done an exam like that in a while.
I was about to say that's bringing you back, I'm sure, to your med school days. And that's a big one, in my opinion. I would probably go down in a blaze of glory if I had to take any 250 question test right now. Yeah. And then the last one, where can they find you guys? Yeah.
So my husband and I, our website for our practice is myacropolishealth.com. I have my patients and my emails out there also. So it's Dr. Meighan, MEIGHAN at myacropolishealth.com. We're not super active on social media right now, so you probably won't find much there, but that's our website.
Okay. Well, that's a no problem, right? Social media is, there's goods and bads to it all, right? But thank you so much for joining me today. I really appreciated this. Like I said, there's people off the top of my head that I know I will be sending this to, because it will be truly impactful for them. So again, thank you for joining me. And please join us next time on the Journey Podcast.